All righty. Good morning, everyone. Thank you all for joining. For those of you who don't know me, I'm Dan Haddad, and today we'll be discussing osteoporosis and the role of the orthopedic surgeon in its management. And before we get started, I just have some questions for some of the residents here in the audience. So by show of hands, who here knows what fragility labs are? Raise your hand. Okay, great. What are they? Start listing them off. Okay.
Vitamin D.
Okay. All right. So you guys got a few of them. Who are you ordering them on?
Fragility fracture patients.
Older patients that fall and get a fracture. How old? What age? Yeah. What's your threshold? 65? Okay. Okay. Anybody who gets a fragility fracture. What is a fragility fracture? Okay. Low energy. Hip fracture, younger patient. Okay. All right. So bisphosphonates, are they good or bad? Who says good?
They're
One or two people raise their hands. How about bad? No one's raising their hands. All right, great. We're off to a good start. So hopefully we can better answer some of these questions by the end of this talk. This topic was kind of introduced at the recent AOA meeting, and it was really very eye-opening. And then recently we had the hip fracture symposium a couple of weeks ago, and that was also pretty enlightening. So I wanted to dig a little deeper beyond the surface understanding that most of us have, especially as residents, really understand the impact on patients, the current standards of care, as well as where we can all fit into the management team. After all, we are the bone experts. So here are some objectives for today's talk, and I want to clarify that this is not an all-encompassing lecture on osteoporosis management. We have colleagues in other subspecialties that are, quite frankly, better equipped and more effective at managing this long-term. The real point of this is to understand the far-reaching impact and identify which patients would benefit from additional intervention, and also to think about other ways that this can affect our patients in ways that we may have not thought about before. So we'll start off with some cases, get into some background, talk about osteoporosis and fragility fractures. We'll get into clinical risk assessment and screening of patients. We'll touch on medical management of osteoporosis, and then we'll finish up with the role of the orthopedic surgeon and what we can do for preoperative evaluation. So our first case, and disclaimer, all the answer choices are going to be the same for all of these cases. So our first patient is a 91-year-old female who had a ground level fall with left distal radius fracture. What is the next best step in management with regards to her bone health? Are you just going to have her be evaluated by physical therapy, occupational therapy, ophthalmology to try to initiate fall prevention measures? Are we going to order fragility labs and a DEXA scan? Are we going to start her on calcium, vitamin D, and an exercise regimen? Or are we going to start her on bisphosphonates? You can call us out in the audience here. Yeah, exactly. That's a good point. So you can do more than one of these. But if you had to just pick one, what is the next best step? Test taking strategies. All right, tough crowd. All right, let's move on to our next case. 55-year-old female, so a little younger, the right distal radius fracture. A couple years ago, she had a bone mineral density scan, and her T-score was minus 1.2. What would you do for this patient?
Yeah, maybe C.
Crickets. All right, I'm glad we're having this talk.
Maybe C.
All right, how about this patient, 85-year-old male, ground level fall with the left femoral neck fracture?
Let's do B and A.
B and A. Okay, so we're getting some talk here. Maybe we don't need a DEXA scan to know that they have low bone mineral density. All right, we're getting somewhere. I think you guys are starting to get the point. All right, next patient's a 60-year-old female. The fall had sustained this left hip intertrochanteric fracture. What are you going to do for her? B, fragility labs and a DEXA scan. Okay. Nails money. Yep. Thank you. All right, how about this patient, 68-year-old female, ground level fall with thoracic compression fracture? B, fragility labs and DEXA scan. All right, or do we need that? Okay, yeah, these are all good questions. All right, how about this guy? 61-year-old male, fell 6 feet from a ladder, sustained this left distal radius fracture and a left femoral neck fracture. Okay, I like the comment. It's not a low energy injury. All right, keep all this stuff in mind. I'm glad that we actually struggled this much to answer some of these questions because I think it just shows that maybe we do need to have a talk about this. All right, so let's get into some background. So fragility fractures are a real health issue facing our aging population. There's over 4 million new fragility fractures that are diagnosed annually, and this number exceeds the amount of new cases of MI, breast cancer, and prostate cancer combined. It makes up a large percentage of the healthcare costs and healthcare burden, results in about 600,000 deaths annually in the US. And for context, the entire world was shut down for COVID, and that killed about 380,000 people in the first year in 2020 here in the US. When you look at the global numbers, the numbers are truly outstanding. This infographic from the International Osteoporosis Foundation, I think, really drives this home. About a third of women and a fifth of men over the age of 50 will suffer some sort of osteoporotic fracture. And that burden that it carries is higher than things like MI, diabetes, breast and prostate cancer, like we mentioned. This paper published in 2023 was looking at global trends in hip fractures, identified over 4.1 million hip fractures. And while most countries did show a slightly decreasing trend in the number of hip fractures, there were still several that had increases like the Netherlands and South Korea. Looking at the US, we had a very slight decrease in numbers. And although we may think that we have interventions to help with this issue, we're actually seeing an overall increased life expectancy, baby boomer surge, and increased population in developing nations worldwide that are all thwarting some of these efforts that we currently have. Looking at projected numbers of hip fractures, the numbers are really astonishing, and it's expected to almost double by 2050. So for those of you looking for stock tips, it's time to buy some stock in intramedullary nails and hemiarthroplasties. Okay, pop quiz. How many bones are in the human body? 206, nailed it. So even after sustaining one fracture, there's still 206 opportunities to break something else. This study, looking at the data from the faith and health trials, showed that within 2 years of a femoral neck fracture, around 11% of patients sustain an additional fragility fracture. All right, another pop quiz. What's the rate of physeal growth arrest with Salter-Harris 2 distal radius fractures? Less than 5%, 2%, pretty low. How often are you telling your patients in the ED that this is a risk when you reduce them? Every time. How often are you telling your patients with hip fractures that there's a high likelihood of breaking something else after you fix them up? Some of the time or none of the time. In this same study, less than 10% of patients in the faith trial and less than 23% of patients in the health trials were receiving osteoporosis treatment at the time of secondary fracture. So what's going on with that? We're very meticulous about making sure our patients are discharged on DVT prophylaxis, but we don't seem to put any emphasis on osteoporosis management. What's the rate of DVT after a hip fracture? Overall? 1%? Yeah, it's depending on the literature, it's about 10 to 30%. It's higher when surgery is delayed. So this should be just as important. This study is titled Death, Debility, and Destitution. I think it's an interesting title and pretty fitting, but I looked at this following hip fracture and found a twofold increase in 1-year mortality in patients with hip fractures, quadruple the risk of long-term residency, and double the risk of falling into a low-income category because of associated medical costs. We have a tendency as an orthopedic community, especially as residents, to see a hip fracture. We see it as a hemi or a nail, easy, slam a gamma. I think we often forget this is still a deadly injury, even with our great advancements in fracture fixation and medical care. And in the past, this was truly a death sentence. This paper published in Injury in 2018, I think does a great job at visualizing the effects of fractures on patients with osteoporosis and increasing age. At a younger age, patients may present with an extremity injury, like a distal radius fracture. And while it causes significant morbidity during the healing and recovery phase, patients eventually return to their baseline function. As their age increases and they continue to experience more and more fractures, the morbidity increases, and we're seeing that they never really return to their baseline. This sets them up for even more morbidity following each subsequent fracture. A lot of people here probably don't realize that President Bush proclaimed 2002 to 2011 the National Bone and Joint Decade. They came up with this bone and joint osteoporosis management guideline to encourage treatment along with the Surgeon General. Did it work? Looking at data from 2010 to 2018, after this bone and joint decade, We're still not doing too well. Only 25% of patients had any screening prior to a fracture, and 8% had a subsequent fracture within 2 years. So back to this Surgeon General report. Anyone have any idea how many orthopedic surgeons were on this? 0. Anyone else? Any other guesses? All right, I'll give you a hint. There were 54 authors overall. There was 1 orthopedic surgeon. So something just does not seem right here. No. So over the years, there's been many efforts to manage osteoporosis and raise awareness, and these are mostly led by our medicine colleagues without much input from the orthopedic realm. The AOA has been working to involve the orthopedic provider with their own The Bone campaign, which rumor has it from a couple of weeks ago, it may be coming to a hospital near you. There's this idea of this fracture liaison service that helps to prevent patients from falling through the cracks and making sure that they get the care that they need. However, we're often the first people that treat fractures, understand the mechanisms of injury and its implications. So let's go ahead and get into osteoporosis and fragility fractures. So let's define a fragility fracture. This is a fracture caused by an injury that would be insufficient to fracture normal bone, thinking low energy mechanisms. But keep in mind that mechanisms can be deceptive. Just because the energy of a mechanism is low does not mean it's, just because the energy of the mechanism is high does not mean that it's not a fragility fracture. They could have also fallen and sustained the same injury. Just because they were in a car accident doesn't mean they wouldn't have hurt themselves falling from ground level. We'll get into this a little bit later, but keep it in mind. So most common locations are lumbar spine, hip, and wrist. And wrist fractures are actually strongly predictive of future fractures, and it's been demonstrated in several longitudinal studies of men and women. Most of these are associated with low bone mineral density, even in the setting of considerable trauma. And basically any recent fracture of any major bone in adults over the age of 50 should be considered a sentinel event. So I apologize. I have to get a little nerdy here and talk about bone physiology. Bone is made up of type 1 collagen, which is produced by osteoblasts as procollagen. There's enzymatic processes that enable formation of cross-linked collagen fibrils, and this contributes to the tensile strength and elasticity of bone. These cross-links can get released with bone resorption, and they release these factors that we know as CTX and NTX, which we'll discuss a little bit later, so just keep those in mind. When we have bone that's formed too rapidly, the collagen gets laid down in a disorderly fashion. We get this woven bone that's mechanically weak and susceptible to fracture. Think of this when we think of Paget's disease or bone metastases. Once this collagen is laid down, we have hydroxyapatite that's deposited between the collagen fibrils, and that contributes to the mechanical rigidity. Removal and replacement of bone kind of occurs throughout life, and about 10% of your skeleton is being remodeled at any given time. We have osteoclast precursors that get attracted to a remodeling site, and they fuse into this multinucleated mature osteoclast that secretes hydrochloric acid and enzymes like cathepsin K. And after resorption is complete, these osteoclasts undergo apoptosis, and that signals new bone formation. These osteoblast precursors will come to a site and mature to form collagen that later becomes calcified. And there's all these signaling molecules get released in the process. So if you're sleeping, wake up. This is pretty high yield for the OITE. There's always a question or two on this. So again, without putting everyone to sleep, osteoclasts do differentiate from stem cells in response to rank L, and that's produced by osteocytes, bone marrow stromal cells, and activated T cells. There's a stimulatory effect from rank L, and that's inhibited by osteoprogenerin, OPG, and that's a decoy receptor for rank L produced by osteoblasts and bone marrow stromal cells. Mature osteoclasts will eventually degrade the bone matrix like we discussed previously. And then osteoblasts, which are derived from mesenchymal stem cells in response to BMPs and other mediators, will come into play. There's several members of the WNT family of ligands that promote bone formation and have a stimulatory effect that's inhibited by sclerostin that's produced by osteocytes. In addition to some of these local factors, osteoclastic bone resorption is stimulated by various systemic hormones like parathyroid hormone, 1,25-dihydroxyvitamin D, thyroid hormone, growth hormone. It's inhibited by estrogen and androgens. And these can also kind of work indirectly by regulating expression of rank L and OPG. All right, that was a mouthful. So how do we get osteoporosis? Bone turnover. In young, healthy adults, the bone turnover cycle is balanced such that resorption is matched by formation. And bone remodeling can accelerate in the setting of chronic diseases, aging, mechanical, hormonal, biochemical exposures like steroids. And over time, this process leads to greater and greater deficits in mineralized bone. Accelerated bone turnover affects cortical and trabecular bone somewhat differently. So bone resorption takes place on the surface of the bone. And because of its higher ratio of surface area to mass, trabecular bone is depleted more rapidly than cortical bone. So with each remodeling cycle, there's a net loss of bone tissue. When the bone remodeling rates increase, again, in the setting of estrogen deficiency, for example, at menopause, bone loss is seen first in skeletal sites that have rich trabecular bone, like the spine. And sites that have a mix of cortical and trabecular bone, like the hip, will develop clinically apparent bone loss later in life. This is a huge list of conditions and medications that contribute to osteoporosis. I have to say, it's pretty impressive, and there's a lot of things on this list. So I'm hoping that I'm making my point that this is a problem. So a little bit about timeline of bone mass. Childhood and adolescence, bone mass is steadily increasing, and patients really have a propensity for fracture at this age because of a delay between laying new bone down and mineralization of that bone. In your early adulthood and about your 20s, fracture rates kind of level off with attainment of your peak bone mass. And from there, it goes downhill. Mineral density does stabilize around your early 40s and declines, and then accelerates at menopause. And you can lose about 2% a year for 10 years after menopause. So it seems like I'm telling you that anyone over the age of 50 with a fracture is doomed, needs to be referred to an osteoporosis center. And I kind of am. So how can we be more accurate with our identification of patients that could benefit from intervention? And one way is a clinical risk assessment to determine if a patient is at higher risk for sustaining a fragility fracture. For example, if a patient shows up to the office that's 90 years old, says that he's climbing ladders, and he has vertigo, but the vertigo is stable, maybe it's a good idea to tell him to stop climbing ladders before he falls a week later and sustains a proximal humerus fracture, LC1 pelvis fracture, and comminuted acetabulum fracture. So let's get into it. How many times have you seen GLF during fracture conference? What does that even mean? Most of our fragility fractures are from low energy falls, but again, don't forget that high energy can be a fragility fracture too. So there's things that we can do for everyone, like a vision assessment, orthostatics, look at their medications, look at neuromuscular conditions, and have occupational therapy get involved in the patient's care. And there's also these fall risk assessments that can be easily performed. There's a 30-second chair stand test where you see the number of times a patient can stand up from a seated position in about 30 seconds. Timed up and go test where you have them stand, walk 3 meters, come back and sit down, and a balance test. And based on how well they do, you can kind of deduce whether or not this patient's at higher risk for falling and eventually sustaining a fracture. That being said, we also have this FRAX tool that's actually pretty useful, and I did not know about it until working on this talk. So most fragility fractures occur in people and patients that do not actually have osteoporosis by bone mineral density criteria, which is a DEXA score, T-score of less than -2.5. There's other factors that come into play. So this risk assessment tool looks at things like race, age, previous fragility fracture, the use of oral steroids, and the data from these risk factors and their relative contributions to fracture have been validated through many population-based cohort studies. And this really gives us a more accurate picture with a bone mineral density score, but it can still provide us an estimate even without. So let's go ahead and get into bone mineral density and more screening tools. So the DEXA scan, this is probably the one that most of us are familiar with, but we probably have no idea who should get one. So the current recommendations are women over the age of 65 and men over the age of 70, regardless of their risk factors. We can kind of bring the age a little bit lower if there are patients with clinical risk factors for fragility fracture. Also include any patient over the age of 50 that sustains a fracture pretty much. Any adults with any condition like rheumatoid arthritis or patients on steroids, anything that you may think that may be associated with low bone mass or bone loss. And I think this quote here is pretty interesting. In patients age 50 or older, consider hip, vertebral, and or forearm fractures to be highly suggestive of osteoporosis or other metabolic bone disease unless excluded by clinical evaluation and imaging. So all these patients probably have some sort of osteoporosis unless you prove otherwise.
So that's all adults over 50 with a fracture should get, I mean, any fracture? Or just kind of the highly suggestive ones? Or?
Yeah, so, specifically hip, vertebral, or forearm fractures, when you think of things like finger fractures, skull, ribs, things like that, those are usually caused by some sort of more considerable trauma. So we don't necessarily consider those to be, the sentinel events or fragility fractures like we are calling them, but certainly something to consider with, and really anyone over the age of 50 with an injury that may not necessarily correlate with the mechanism of injury. So ground level falls, twisting their ankle and having a really comminuted ankle fracture, things like that may be considered at least worth it to get further investigation. So making sense of these scores, I think most of us have a basic understanding of the T-score. So it's normal if it's -1 and above. We couldn't consider it low bone mass or osteopenia from -1 to -2.5, and osteoporosis at or below -2.5. What's also interesting here is that we can also have clinical criteria for osteoporosis diagnosis in postmenopausal women and men over the age of 50. So if you sustain a hip fracture, a vertebral fracture, and a forearm fracture, these are consistent with osteoporosis unless you prove otherwise. So automatically, these patients are diagnosed with osteoporosis unless you get a bone mineral density score and you prove that it's not the case. You can also use the FRAX score to help with this as well. And this was really eye-opening for me to learn that we're probably underestimating how many of our patients are on their way to another fragility fracture. So bone mineral density really only accounts for about 70% of fracture risk. The T-score is a pretty specific test, but it's not really very sensitive in terms of predicting future fracture risk. So there was one study that looked at women over the age of 65, and more than half of those that sustained hip fractures actually did not have osteoporosis by bone mineral density criteria. So I think these next two tests we'll talk about give us a more complete picture of bone strength and fracture risk. And one of these is a vertebral fracture assessment. So prior vertebral compression fracture plus bone mineral density on a DEXA scan is the strongest predictor of bone strength. And, unfortunately, a lot of patients don't really realize that they have a compression fracture. How many times have you gotten called in the emergency room for age indeterminate compression fracture found incidentally? You go and talk to the patient. They have no idea that they ever had one. And this happens all the time. But the presence of a single vertebral fracture predicts a 5-time increased risk of subsequent vertebral fracture and a 2 to 4-time increased risk of a subsequent hip fracture. And these tests, again, are mostly done in conjunction with a DEXA scan. I won't bore you with all the details, but basically the indications to get this study are pretty broad. All women over the age of 70 and men over the age of 80, if there's a bone mineral density T-score that's less than 1. And then we start looking at things like postmenopausal women and men age 50 or older with specific risk factors, like a low trauma fracture during adulthood, loss of height, or recent or ongoing steroid treatment. The trabecular bone score is also a very valuable tool, and it's a non-invasive analytical method that looks at bone strength and quality. And basically, it's derived from lumbar spine DEXA images, and they process it to create this 3D projection of trabecular bone. And it gives us more information on the microarchitecture. And it's really especially helpful for these patients with a DEXA score above 2.5, negative 2.5, where we may kind of be in that gray area. So all of these tests are really serving a purpose to give us extra information and a more complete picture of a person's bone mineral density and their fracture risk. So these are common labs that are commonly tested for patients that we're working up. And I won't go through each one of them, but a lot of you guys called out some of these. And we get a handful of these in our fragility fracture workup here at the hospital. And the goal is really to correct any underlying cause of osteoporosis and to optimize and ensure that patients can tolerate medical management if we decide to go that route. Speaking of medical management, let's go ahead and touch on that. So once we've made the diagnosis of osteoporosis, what do we do? I think this next section may be a little dry for some of us, but I think it's important to at least understand what interventions we can all be doing for our patients, which patients we can refer to someone else who can oversee the pharmacologic management and have a basic understanding of the meds. So what can all of us do to recommend for our patients? Vitamin D is crucial, and here in the Northeast, we probably should all be taking a supplement. There's significant vitamin D deficiency can be managed with large doses to build up stores, and then you have a maintenance dose of 1,000 to 2,000 international units daily. And this is just over the counter. Vitamin D is fat soluble, so it is best to take it with food for optimal absorption. And then the question always comes up of, can you overdose on vitamin D? Can you take too much of it? And the answer is yes. The consequence is usually hypercalcemia, and you get symptoms like nausea, vomiting, muscle twitching, things like that. But it's relatively uncommon. You really have to take a lot of vitamin D. Calcium is important as well, and it's best to encourage patients to get it from their diet. You want them to get at least 1,200 milligrams a day. Supplements are great, but there are some studies showing increased risk of cardiovascular events and mortality with excessive supplementation. And then we have lifestyle modifications. So this is great for everyone to do at all stages of life. Weight-bearing exercise increases bone mineral density and muscle strength. Smoking cessation and alcohol are obvious ones. And here's one that you probably don't want to hear: caffeine. This can actually interfere with calcium absorption. And, putting a little bit of milk in your coffee can actually offset this a little bit. So for my fellow Black coffee drinkers, we have to make sure we're getting enough calcium and vitamin D in our diet from other sources. Fall prevention measures are probably really overlooked, but this is multifactorial and requires us to refer patients to ophthalmology, OT, and other interventions to help minimize fall risks at home. And it's probably something that we don't really do enough. So pharmacologic management: who should be on pharmacotherapy? Anyone really with a hip or vertebral fracture should be considered for this at least. Anyone with a wrist fracture over the age of 50 with a known low bone mineral density score, anyone with a T-score of less than 2.5, and anyone with a low bone mineral density and a high FRAX score. The target that we're treating to is absence of fractures, stable bone mineral density, or increasing bone mineral density. So that means that we're repeating these tests and not just giving medications and leaving patients to them. This is a long list of medications that can be used for osteoporosis management, and we'll get into some of these. For the sake of time, I won't bore you guys with this slide, but I think it's pretty helpful to kind of contextualize where all these drugs kind of fit in. So if you want to take a picture, you can go ahead and reference it later. But we'll go ahead and get into these drugs. We'll start off by talking about bisphosphonates. So before we talk about that, I know what you're about to say. What about all these pathologic fractures we get? If the intern has to put one or more of these in traction, they're going to lose it. So the risk of femur fracture is actually incredibly low. It's about 0.16 in 1,000 patients. This risk does double with prolonged use over 3 years, but it does decline with discontinuation. So this is where drug holidays may come into place. But however, the risk of osteoporotic fracture is much higher. And I think this kind of graphic illustrates that pretty well. So with regards to bisphosphonates, there are two major classes: non-nitrogen containing and nitrogen containing. Again, this is pretty high yield for the OITE. The non-nitrogen containing ones, we don't really see these used as often, but the mechanism is through inhibition of osteoclast farnesyl pyrophosphatase. You have nitrogen containing ones that are the ones that we see more often, like alendronate and zoledronate are probably the two most common ones that you probably see in patients in the emergency room. And basically, this induces osteoclasts to undergo premature death and apoptosis by forming a toxic ATP analog. What's important to know about these medications in general are that they are renally excreted, so some patients may not be candidates for this. They do decrease spinal fusion rates. So Matt, I'm sorry, you may have to deal with this and figure this out moving forward. The oral formulations have overall poor oral bioavailability, and you must remain upright for about 30 minutes after taking these because of the risk of developing an esophagitis. So again, I'm not going to get into all the details, but I think it's great to look at some of the data that each of these drugs kind of presents and the risk reduction. So alendronate can reduce risk of incidence of spine fractures and hip fractures by about 50% over 3 years in patients with known osteoporosis. Boniva, again, reduces vertebral fractures by about 50% over 3 years. Actonel, same thing, 50% over 3 years. Reclass or zoledronic acid, this one is a little different. It's a yearly infusion, so that may be a little bit easier for compliance. Reduces vertebral fractures, hip fractures, and non-vertebral fractures. And what's great about this is we have data that the number needed to treat is 15. For those of you not really familiar with drug trials, this is pretty good. So for every 15 patients you're giving this to, you're getting at least one patient that you're saving from a fracture. We have hormonal targets. We have calcitonin. And this is approved for osteoporosis in women 5 years that are postmenopausal. It comes in a nasal spray and an injectable. But what's different about this is that it may not actually increase your bone mineral density. It reduces fracture risk by about 30%, so it's a little bit more modest. And it's not really shown to reduce non-vertebral fractures. And this is really only an option for patients that can't tolerate other options. Some additional estrogen hormonal therapy. Again, we're not really seeing this in the orthopedic realm, but there's many formulations and additional indications that these can be used for. So it's good to know if you see a patient on one of these that this may also be helping out. And, our primary care colleagues may use these medications in certain patients. The risk reduction is a little bit more modest, about 34%, 23%, but the trade-off is you get an increased risk of MI, stroke, breast cancer, PE, DVT, and bone loss can be pretty rapid once you discontinue it. We have our selective estrogen receptor modulators like raloxifene, and again, the reduction is a little bit more modest than our bisphosphonates. There's no evidence on non-vertebral fractures really. It's also used for reduction in breast cancer, but we have an increased risk of DVT. All right, let's get into it. Our bone anabolic agents. These are some of our newer drugs that worked really well. Currently, these are FDA approved to treat osteoporosis in postmenopausal women and men that are high risk for fracture due to multiple risk factors, including steroid therapy, and those that remain at high risk despite treatment with other medications. So it's really a small subset of patients. These work by activating osteoblasts, and they work on your renal tubule cells and stimulate intestinal absorption of calcium and phosphorus. Again, they're approved for patients that are high risk. You can get a wide slew of side effects from these medications, and they're contraindicated in Paget's disease because of an osteosarcoma potential risk. So not a benign drug. You can't use this for more than 2 years at most. And usually you follow this by a bisphosphonate to maintain that bone mineral density that you generated. But looking at the data, it's actually pretty good. So, we have numbers like 57% reduction after 18 months of therapy. And looking at the bisphosphonate data, it was all 3 years, and it was more modest than this. We have 57%, 65%, and this last drug, Evenity, reduces vertebral fractures by about 73% at 1 year. Again, we have no other drugs that do this, but they come with a trade-off. Here's another one, a rank L inhibitor, denosumab or Prolia. You probably hear a lot of patients on this. It's an injection that you get twice a year, and again, it has great reduction in vertebral fractures and hip fractures. But again, you can get some bone loss once this is discontinued. So the question is, does this stuff work? This study was actually just recently published a couple months ago. It was a case control observational study. They started with about 270,000 patients over the age of 65 with a CT scan that gave them a free look at the hip. And then they sorted it into those who had a first hip fracture after this CT. They looked at those that had bone mineral density testing, and were treated for at least 6 months with prescription medication. And out of about 2,000 patients, 34% of women and 24% of men were treated with alendronate, and the rest were not treated. 32% of women and 12% of men had their first hip fracture after that CT scan. So the odds ratio of a hip fracture for treated versus non-treated was 0.26 for females and 0.21 for males. So basically the conclusion is that osteoporosis treatment prevents hip fractures similarly in both men and women. So these medications work. So I briefly introduced the concept of a fracture liaison service a little earlier, and basically it starts here in the top left corner with the healthcare system, working to identify patients that have fragility fractures. And it works to basically investigate and develop a fracture risk assessment. You develop a personalized treatment plan along with the primary care physicians, and then you have long-term monitoring for treatment initiation, adherence, the goal being reduce the number of fractures, reduce readmissions, and overall improve their health. This was initially developed about a decade ago, and it's really formed with a multidisciplinary team. Usually it's overseen by this FLS coordinator that's usually an APP, and it's been really shown to reduce fracture recurrence. The Kaiser Healthy Bones Initiative showed a 38% reduction in fragility fractures. Geisinger has their own program that showed about $7.8 million of cost savings over 5 years. We have AOA that has developed Own the Bone that, again, may be coming to a hospital near you, and then Capture the Fracture by the International Orthopaedic Foundation. So we also have systems in place here in our private offices as well, with assistance from the Rutgers Osteoporosis Center. So we have a lot of great resources to get patients plugged into the system. They can see an endocrinologist, whoever else they may need to manage their bone health. However, it still comes down to us really identifying these patients and referring them. We are looking at the fractures, we're seeing their bone quality, and we need to do something about it. These 2019 clinical recommendations for secondary fracture prevention were developed, and basically the recommendations were anyone over the age of 65 with a spine or hip fracture should be managed by an FLS. Primary care providers should be informed about fractures, osteoporosis diagnoses, and future fracture risk. We should get all these patients evaluated by PT, OT, ophthalmology, trying to initiate fall prevention measures, and we can offer pharmacotherapy to a lot of these patients. And really the ideal scenario would be that we start it in the hospital prior to discharge. And long-term follow-up is important. Now, I know what the next question is going to be. What about the bone healing? Do bisphosphonates cause non-union? Do we want our patients walking around like this? No, this is not Popeye. This is a humerus non-union. So this was a retrospective analysis of Medicare claims from 2016 to 2019, patients over the age of 65, surgically managed, and they looked at CPT and ICD-10 codes. They had 111,000 fractures, and 9.4% of them had a diagnosis of non-union at 1 year. When controlling for race, age, sex, neither bisphosphonates nor the hormonal targets were associated with non-union. And they looked specifically also within the 90 days post-fracture, and there was no significant association with non-union. Timing of medication didn't matter at all either. And again, this was published in JBJS in 2023. So, good data and very high numbers to look at. So what's the role of the orthopedic surgeon? And I want to clarify, I don't expect or even think that orthopedic surgeon should be managing bisphosphonates or other forms of pharmacologic management besides maybe vitamin D and calcium. But we see these fractures first, and we can be the first person to identify that there's a bone mineral density problem. We've seen data here that osteoporosis and fragility fractures are a problem, and the number of expected hip fractures are going to double in the next 25 years. So if we're going to keep up, Dr. Sahabian is going to have to develop a whole second hip fracture protocol. So maybe there's something that we can do to stop this. The AOAs basically come up with these suggestions for orthopedic surgeons to help overcome osteoporosis in the community. And I highlighted a few here that I think are easy for all of us to kind of easily implement in our practice. So anyone over the age of 50 with a fracture should be evaluated as potentially osteoporosis related. So even this, 61-year-old that we had earlier, just because he fell off a ladder 6 feet doesn't mean it's not an osteoporotic fracture. Could have just as easily tripped and fell and sustained the same injuries. And then we would be calling it a fragility fracture. And mind you, this is a wrist fracture and a hip fracture, 2 out of the 3 that we consider to be high sentinel events. Consider a preoperative bone health assessment and optimization in elective patients over the age of 50. We'll get into this momentarily, and utilize fracture liaison surfaces. This was a survey that was performed of 465 arthroplasty surgeons, and 77% of them indicated that poor bone quality would influence their decision of implant. But only 5% of them actually tested their patients for osteoporosis. A similar survey of surgeons at the 2018 AOA annual meeting found that 78% of surgeons believe that osteoporosis influences the choice of implant for arthroplasty, but only 10% of them recommended DEXA scan. So, looking into some of our elective data, this meta-analysis found that there was a rapid and significant decrease in bone mineral density after a total knee arthroplasty that did not recover even after 2 years. There was about a 15% decrease, and that occurred within the first 6 months after a total knee arthroplasty. And the peak was by 12 months, and that really was sustained for about 2 years. This basically increases your risk for periprosthetic fracture, and there's similar literature for around the hip. And I don't have to tell you that these periprosthetic fractures are a disaster. I think we all know that. This study looked at mortality and complications after periprosthetic fracture in patients that were managed with open reduction, internal fixation, locked plating versus distal femoral replacement. And 90-day mortality was about 10% for plates, 8% for distal femur replacements. At 1 year, it shot up to about 25% and 19%. And only about 50% of these patients regain any sort of mobility after these injuries. So significant morbidity. So can we do anything about it? And I think so. This was an interesting study looking at zoledronic acid, and it really didn't effectively inhibit the loss of bone mineral density around the prostheses. It looked at the Bruin zones and found that there was a significant decrease. There was a significant lower decrease in bone mineral density. We also have data on zoledronic acid looking at bone resorption. So like I mentioned earlier, we have markers of bone resorption like CTX and NTX. And many studies have reported that it can actually reduce the amount of these serum markers. So this showed that zoledronic acid had a strong suppressive effect on bone resorption markers at 3 months after surgery, and this lasted up to a year after a total hip arthroplasty. For our spine colleagues, I'm not going to leave you guys out. This study showed that poor bone quality was associated with increased cage subsidence. Call me Sherlock, that seems obvious. So this study looked at postmenopausal women with osteoporosis that were undergoing instrumented spinal fusion with or without 1 month of preoperative teriparatide. This significantly increased pedicle screw insertional torque, and this has been shown to previously to directly correlate with pull-out strength. So what are we going to take away from here? Osteoporosis and fragility fractures are a growing global health issue. It's important for all of us, especially as orthopedists, to identify patients that could benefit from further evaluation and work closely with fracture service liaisons. I think more people should probably be on bisphosphonates than you think, and they're not all bad. The overall risk of atypical pathologic femur fracture is significantly much lower than the risk of an osteoporotic fracture by not taking these medications. And I think it's important for us to consider a preoperative bone mineral density test and a referral if it comes back positive. And back to our cases, the answer is that almost all of them probably could qualify for a bisphosphonate without even getting the DEXA scan and fragility labs. I think it's a good idea to get those, establish a baseline, confirm your diagnosis, but we probably could have started almost all of them on bisphosphonates in the hospital before we left. I think a good analogy here to bone mineral density is hair loss. You want to initiate measures like Rogaine before you lose all your hair, and then it's too late, unfortunately, like for our friend Mike Simon, Jeremy Silver, who's not with us today. These are some references, and thank you for your attention. I'll take any questions.
I have a question. First, that was a great review, really excellent presentation. Isn't it true that more than 90% of people who break their hip actually have a fall or an injury?
Yes.
So how can you, the data says that if you take the medicine, I mean, you showed one slide where there was a 50% reduction in the rate of fracture. Don't you have to have a denominator and know all the people that fell that were on the medication versus all the people that fell that weren't on the medication? Because what if, the people that fall, if you're on the medicine and you don't fall, it didn't prevent anything. So if you don't have that denominator and have the same number, how do you come to that conclusion?
Yeah, I think I understand kind of what you're getting at. So I mean, it's not a perfect study, but I think they have pretty large numbers, and looking at patients that were on treatment versus patients that were not on treatment, I think you're kind of taking into account that their fall risk is probably pretty similar in both of these groups, especially with the large numbers that they had. So I think the risk of them falling was probably equivalent. And yeah, sure. I mean, I guess you can contribute some of the difference in numbers to patients just not falling. But I think if you assume that their fall risk was equivalent, I think you can kind of take the data a little bit more, trustworthy.
Yeah, I think it's like the rate of fracture that you would expect versus, what you see in those, and you compare it in those two groups in that same at-risk population. So yes, you don't have a true denominator per se.
Well, falling is the key to the whole thing, and exercise and other modalities that are not pharmacologic could help decrease and minimize the rate of falling. Yet our main concentration is on medication. And a lot of these elderly people come to the office, they're on a ton of medicines, heart medicines, everybody's on anxiety medicines, depression medicines, medicine. A lot of people don't want to take them because in today's day, everything's treated pharmacologically. Don't you think, I mean, we have so many, 300,000 people have a hip fracture a year. Don't you think we can get that information? Can't we be able to do a study that determines of the people that fall and break a fracture and break a bone, what percent of those people who fell or broken, those that didn't break, who's on the medication, who's not, so we have a better idea? It just seems odd that there's you're telling us you have 50% decreased risk of breaking your bone when every year the rate of hip fractures goes up. And you would think that the rate of use of these pharmacologic agents, if anything, goes up, not down. The rate of hip fractures keeps increasing, yet we have all this data.
Sure.
Yeah, I think that's a really good point. So a couple comments to that. I think first of all, I think the fall risk assessment tests that we have and having interventions where we can, encourage patients to get physical therapy, exercise, involve occupational therapy, ophthalmology, involve our neurology colleagues for patients with neuromuscular disorders. There's all these things that we need to do that we are not doing currently. And I think that, a lot of these patients fall through the cracks. We just say, oh yeah, they're old, they're demented, they're out to lunch, and we don't really do anything about it. So I think that's 100% agree with you. I think that's an easy place. It's low hanging fruit, doesn't cost that much, low risk to patients or almost no risk to patients. And I think it can really help. So that's definitely something that all these foundations are pushing for. And it's just not as, sexy because you can't bill for it as well as, medications. That's just kind of the reality that we live in. So that's the first point of that. And then, in terms of the medications, I think the medications definitely have a role. And, I think our goal is really to refer patients to these services to get them kind of linked in. But they're not the end all be all.
So explain to us why the rate of hip fractures keeps going up.
Yeah. So, sorry. So let me find that slide. So, but
Dr. Kirschbaum, doesn't an at-risk population keep increasing? Isn't it the whole point of this talk that the at-risk population is increasing, but our use of the modifying agents is being outpaced by that, right? So we should be doing more and more of these agents or more of these interventions, and we're not. And so the patients who are at risk for hip fractures that population keeps growing, and we're not keeping up with that.
Yeah. So exactly to Jomar's point, and this study that had data from the FAITH trial and the health trial, less than 10% of patients in the FAITH trial, less than 23% of patients in the health trial were actually on osteoporosis treatment at the time of a secondary fracture. So not even the primary fracture. So after they broke a hip, they broke something, they were seen by the medical team, they were seen by an orthopedic surgeon, they were seen by their primary doctor, and of less than 25% of patients were started on anything. And this number has not really changed. So, I think people are just underestimating what patients need to be on something. And then, we do have an aging population with baby boomers. We have increased life expectancy. People are living longer, and, developing nations are also kind of coming into play here, where we're seeing these increased numbers globally as well. So I think that's where the higher numbers are coming, even though we're becoming more aware of this. We're just not implementing it, and there's just more people in the pot.
Dan, very, very good presentation. But in your research, did you come across anyone recommending that you look at this from the opposite direction? That is, once you've got someone over the age of 50, 60, and they have osteopenia and osteoporosis, the horse is already out of the barn. And given the fact that we peak our bone density in the late 20s or up to age 40, and the amount of bone mass that you start with will determine what you end up with when you're 85 or 90 degrees. Is there any place for screening 20 to 40-year-olds who are less than optimum in their bone density, and they still have the opportunity to increase their bone density? So once they start declining, they're starting from a higher level.
Yeah, that's a good question. I did not see any studies on that. I'm sure it might exist, but I just personally did not see any literature looking at that.
Yeah.
But that is a good point, and I think you know, good health literacy where you can kind of maybe implement this in schools or even just your primary care provider or pediatrician should probably. That's probably a good place to start because we're probably not getting enough vitamin D even from our childhood, especially here in the Northeast. And you know, our exercise rates are probably not that high anymore. So yeah, I agree with you. I think we're kind of starting off from a bad place, and that's probably an easy place to also start when you're young and healthy.
Yeah, and an example of that is gymnasts and female aerobic athletes who are amenorrheic during their, college years or adolescent years because they're at a high level. They do show earlier onset of osteoporosis than the general population because to Dr. Malberg's point, they are starting off with a lower bone density than they would have if they had had a normal, menstrual cycles and things because they have you want to continue to call it female athlete triad type of thing. So kind of an interesting point by Dr. Malberg that we don't really think about very much.
Yeah, for sure.
It's interesting too, because when you look at bone mineral density in kids, and a lot of parents do come in and ask about this, we don't have normative data. And if you think of how you look at if someone has osteoporosis, it's a bell curve. So if you did a bone density scan in a kid, they're gonna look low just from that natural curve, right? But we don't have what's normal for like an 8-year-old or 9-year-old or 10-year-old. And it's a lot of radiation. So it's a hard thing to look at to see where they really should fall before they're 20, which is really when you're building up your bone mineral density.
Yeah, go ahead, Paul.
Dan, that's an important talk for the residents because, the academy and, and the board have all, kind of emphasized the importance of the role of an orthopedic surgeon in osteoporosis management. And I would tell you that, I wouldn't be surprised in your part 2 examination when you present a hip fracture and you think you know everything about the best way to fix a hip fracture, your questions and discussion focus on the osteoporosis management of that patient because it's almost like a mission of the board and the academy to make orthopedic surgeons be more cognizant of the fact that we do have a role in this part of the patient management.
Thank
It
you.
was a really good talk. It was great.
I totally echo that. Agree. Great talk, Dan. Great summary and some new information. But I want to push back just a little bit in that your recommendations, which are very important, are some of the recommendations that we've been talking about for a decade. The Own the Bone decade, I don't think went very far. And it seems like we have to do more. Someone has to do more. And some of your recommendations are to make sure we screen these people and get them to their primary care doctor and get the proper treatment. But I don't know if that's really working. There's so much pushback from patients when I talk about bisphosphonates to them. It's almost not worth talking to them. I do, but they really push back because they're worried about all the side effects. And my usual comment is, well, the side effect of not taking these is another fracture and another surgery. So, and they sort of get it, but I feel like we have to do more, and I don't know what that is. But one of my questions, or 2-part question, is why don't we teach residents how to prescribe bisphosphonates so we can prevent losing the patient to nowhere when they leave the office? And should we give the patients they get an annual injection, whatever it is, Prolia? Why not give them the first one while they're still in the hospital? Can we really start doing that? So then they're already one injection down. They don't need another one for another year.
Yeah, that's a great point. And actually, the new recommendations are, start it on prior to discharge. That's kind of the best time to do it before they're kind of lost in the system. They don't follow up or whatever it may be. So starting it right on discharge, and then that also kind of increases patient buy-in because they're like, oh, I'm in the hospital for a hip fracture or whatever it may be. I probably should take this seriously, and this is part of my treatment care. and we have data showing that it does not increase non-union rate. To your other part of the question, should we as orthopedic surgeons be prescribing bisphosphonates? I think that's a tough question. You know, I think if you're comfortable managing it, I think that's great. Should we be teaching residents how to do it? I think it's not a bad idea to start a patient on this, but then you have to think about what's going to happen. Now, anecdotally, how many patients have we seen they're on bisphosphonates for 10 years and they're like, and you're asking them, oh, who's prescribing it for you? Oh, I don't know. I've always been on it. Has anyone reevaluated you? Have you had a new bone mineral density test, DEXA scan? No, not really. So, you know, if one physician starts the medication, you know, usually whether it's, you know, poor follow-up or, you know, the primary care doctors are just busy and overwhelmed. For some reason, they're just on these medications long-term and no one is taking ownership of it. So I think what needs to happen is someone needs to take ownership of prescribing these medications, monitoring patients because they are renally excreted and can be renally toxic. So they're not totally benign. Now, you know, they're not incredibly terrible drugs. I think the risk of osteonecrosis of the jaw and atypical femur fractures are probably overblown. But you know, I still think that someone needs to be watching these patients when they're on it. There's nothing wrong with giving them an injection and then, you know, having them follow up with someone else in a year. But again, unless someone is taking ownership of following this up and looking at adherence and continuing these medications, it kind of ends up getting lost somewhere.
What's the additional risk of breaking your bone if you're a smoker and you're an alcoholic or you have a heavy drinking history?
I don't have exact numbers off the top of my head, to be honest with you, but I mean, it's
Didn't
definitely
talk about
more.
Lou Levine that way, Dr. Kirschenbaum.
That's why I'm asking.
Yeah, I apologize. I don't have numbers off the top of my head.
Because we know it's higher, and those are two easy things that don't require the patient to take anything. That's something we should be doing, and it's pretty simple. But you may get the same type of pushback where, you know, people don't want to stop the fun things they're doing, so they just add something else to it.
If you think getting people to stop smoking is easy, I'll send them all to you.
No, I don't think it is. It's just like it's not easy to get people to take more medicines, but that would be the simplest way to approach it.
Yeah, smoke cessation, alcohol, decreasing excess alcohol, and also caffeine. I mean, we underestimate caffeine, and all of us are guilty of this. We probably drink a few cups of coffee a day. I don't know exact doses, but I mean, the studies that we have are not looking at, you know, high excess doses. The point is that it decreases your calcium absorption. And it has those effects. So if you take it with a little bit of milk, that actually does, all you need is like a tablespoon or two of milk in your coffee, and it actually decreases that risk. I personally don't like milk in my coffee, so that's a problem, but you know, I'll deal with it. It's actually, yeah, the calcium and the fat in there does help. Yeah.
I saw you recommended the PT, OT, and optho. What is the optho consult like for exactly? And is this something based on how we're ordering geriatrics consults on all of our hip fractures? Should we also be ordering optho consults on these fractures that we see that are likely fragility fractures?
Yeah, good question. So it's just really if you have an issue where you're not seeing well. So whether that's just poor vision, just general vision loss, whether it's glaucoma, cataracts, you know, things that affect your vision and ability to see your environment, you know, as you kind of age, you may not realize that, you know, you're losing vision or things are kind of affecting your ability to see. So having a formal evaluation is helpful. I don't know that you need it in the hospital. I think an outpatient evaluation is totally appropriate, but again, recommending that is something we probably don't do. I don't think we'll ever get ophthalmology to come here. Yeah, for emergencies, but it's like you know, they're out of their element.
Second question I had was, I noticed you put a long list of fragility labs up, and I feel like we're often told to order fragility labs on patients. And so for your, you know, patient that comes in, they don't necessarily have a history of multiple myeloma. They're just an elderly patient with maybe hypertension, hyperlipidemia. Are we ordering all of these, or which ones do you recommend that we're ordering? Because I feel like there's no standardized list that we typically order. So
here at Robert Wood, there is a standardized order set, but it does not include most of these. It just has like half of these. These are the official recommendations. Everything on this list from serum, urine, Yeah, it's kind of a specialty test. And then markers of bone turnover, CTX, NTX is also a specialty test and kind of more research based. But we probably don't need to order. But everything in the serum is probably something that could be ordered besides, myeloma labs and testosterone gonadotropin, unless you're endocrinology.
Dan, along with that, do you have any idea of coverage for these tests? I mean, we're going to order these across the board. There are some things that, particularly patients on Medicare Advantage programs, where they can turn around and get a bill for some rather expensive testing.
Sure.
Because the insurance determined that there was not an indication for, say, liver function studies with a hip fracture and no history of liver disease. So you have to be careful what you're ordering, because that can affect the patient's financial problems.
For sure. Yeah. And we know that a lot of patients, fall into a lower income class from these injuries. But I think most of these serum tests are generally covered and accepted, besides, again, like some of these hormonal studies that may be more specialty based, but the rest of these should be easily covered and part of a kind of a complete panel.
Hello. I had a couple questions. One, the periprosthetic fracture study showed that there's decreased bone mineral density after these. Did they have any recommendations on these patients for after surgery?
Yes. Let me pull that up. Yeah. So this study looked at zoledronic acid post-op from a total hip replacement, and it showed that there was a slightly less decrease of bone mineral density with using zoledronic acid. They looked at all these different Gruen zones. So
What was the other study that showed like,
this one,
no, it was like once you get like a total hip or a total knee, there was a decrease.
yeah, this one
Yeah.
was just identifying the problem.
Yeah, so
They had-
that study didn't talk about anything as far as
No.
prevention.
This one specifically did not. This was just kind of identifying that this is actually a problem. And then this study here specifically looked at the use of bisphosphonates and the effect on bone mineral density after elective surgery.
And then the one study on there's no differences in non-unions. So I'm trying to think, I feel like most of the people here, especially if they're on bisphosphonates, we generally recommend, I think, 2 weeks holding them.
Right. But there's no difference.
So not across the board, intertrocks, anything.
Yep. Distal tibia frac, whatever. No difference. Except if you're doing spinal fusion, that's the only place where it actually matters.
And then
that we have data on.
So there was a study for pre-op spine patients, giving them bisphosphonates or whatever to increase pull-out strength of pedicle screws. But when do you stop that then to not decrease the rate of fusions post-op?
Yeah, so this was just 1 month of preoperative teriparatide, and that's one of the kind of anabolic agents. So they just did just 1 month just to increase your bone mineral density before surgery. And again, I think this is a field that we don't have a lot of information on, and I think we need to kind of explore this and research this a little bit more. Doing these interventions preoperatively to have better postoperative outcomes. In what setting? Okay, so you're not saying a pathologic femur fracture. You're saying they're on bisphosphonates and they have a regular standard of the mill femoral fracture. Yeah, you probably don't need to stop it. Yeah, but I think that's a reason to maybe have them follow up and see, why did they refracture if they're on bisphosphonates? And again, it's not a perfect drug. You're still going to sustain fractures, but was there an adherence problem? Is there some other underlying issue that we're not identifying? So I think that should kind of ring the alarm for further workup.
But Dan, on that study with the periprosthetic fractures for total knees, did they posit a mechanism for loss of?
Yeah. So kind of the main mechanisms are kind of like the concept of like stress shielding. So you're not really putting as much stress on those same surfaces that you would if you just had a native knee. That was really kind of the main postulated mechanism for this.
It was interesting that Fred Tria a number of years ago did a study on, I think it was 100 patients, 50 below obesity and 50 above, and those who were above the obesity scale at 2 years post-op had actually gained weight rather than lost weight. And so you wonder the fact that they wind up being just as, if not more sedentary after
Right.
total knee replacement,
Exactly.
leading to more osteoporosis.
For sure. All righty. Well,
Dan,
thank you.
Swan here again. Just one of the things you run into on in the community is, who do these patients follow up with? Their primary doctor. Sometimes it's the gynecologist who's prescribing medications, or does the DEXA, a bone endocrinologist or a regular endocrinologist. Good luck getting an appointment with them. And I often wonder, why don't we, as a group, employ a bone endocrinologist, have them in our office, or at least have one nearby that's what they do. And it seems like a, a, a vacuum in the community, and it ought to be filled. And if you guys have a friend or a family member who's thinking of going into medicine and not sure, like bone endocrinology, like they're going to have an explosion of patients as we go forward, and there's no call.
Yeah, that's a great point. And I think that is absolutely a huge problem that we have, because again, we don't really have anyone taking ownership of this. We have a bunch of people that are trying their best and trying to help out, but no one is really saying, hey, look, I'm going to be the bone expert, or the osteoporosis management person here. And that's, I think, where the concept of this fracture liaison service comes into play. And these are becoming a little bit more widespread, where you have an APP that's overseeing the care of these patients. They can start them on a bisphosphonate, they can order the DEXA scans, all the other studies, and then kind of send them in the right direction. Here at Rutgers, we have the Rutgers Osteoporosis Center that's staffed by endocrinologists. At the UOA office in Somerset, at least, we have Patricia Seifert that does a lot of this work. So, there are initiatives, and I think if Own the Bone, the AOA Own the Bone initiative does come to Robert Wood, I think that'll be another mechanism that we have to kind of work with that. But again, it's 100% a problem, and I think that's why we're not seeing improvements in our rates of patients that are getting treatment, because we just don't know who's gonna deal with it. That being said, I think endocrinology is important for identification of actual endocrinological problems, but some people might just need to be on a bisphosphonate, and it does not need to be so complicated. A regular primary care provider is more than capable of managing it.
Agreed. Thanks for highlighting it.
The last question I had, was there stuff as far as like decision making on which drug to use when, nitrogen versus non-nitrogen, bisphosphonate versus teriparatide, denosumab, or is it just like the Wild West and we're just throwing one?
Sure. Yeah. So I think bisphosphonates are still kind of the first line. Going back to this slide, so the non-nitrogen containing ones, they're fine, but you just don't really see them used as much. The nitrogen containing ones are a little bit more commonly used. I think that's just a kind of a convenience thing. In terms of using the anabolic agents, again, those have very specific indications for people that are high risk, that have failed other medications. You can only use it for up to 2 years at most, and you have to follow with a bisphosphonate. And the other agents that are out there really are reserved for patients that can't tolerate bisphosphonates, because again, you have renal excretion, you have poor bioavailability, so you have to, and you have risk of esophagitis. So there's all these things that kind of make it a little bit harder to tolerate. All right, awesome. Thank you all for your attention.